Good morning, everyone. Thank you for coming on the last day of the conference fairly early. It's been a good but tiring couple of days. I'm really excited to talk about second last day, of course. I think in my head I was like, today if I make it, tomorrow it's an easy day. We'll be talking about something that's been really topical in the HIV community, which is weight gain after HIV therapy initiation, talking about the pathophysiology and implications. These are my disclosures. There seems to be a lag between what I can see and there, but I'll continue. So the objectives of this talk, I'm going to be talking, giving a summary of some of the evidence that we have from clinical trials, both within Africa and outside, talk about the consequences of excess weight and obesity among people living with HIV, speak about some of the clinical implications, and also what this possible strategies that we can have in our context. So HIV has changed. Antiretroviral therapy has changed the life expectancy among people living with HIV. All throughout the world, we can see with the figure in front of us, and this is a study that was done by colleagues from South Africa, modeling study, where they looked at the life expectancy at 20 years at 2 time points. And as we can see, life expectancy has increased all around the world. And this is through the success of antiretroviral treatment. It's safer, easier to use, and more potent. However, while life expectancy is generally the same in most populations, among people who are living with HIV and those that who do not have HIV, what you may not know is that people living with HIV have 16 fewer good years in good health. This is mostly due to cardiometabolic complications, some cancers, osteoporosis, fatty liver disease, kidney disease, and dementia. And all these diseases that are put up there are in part due to excess weight and obesity. While obesity is a growing epidemic everywhere in the world, currently, according to WHO statistics, we have approximately 2 billion people who are living with overweight, and of those, 650 million people are living with obesity, which is classified as a BMI greater than 30. BMI is not necessarily a good measure of individual health, but it does give us an indication of who is having obesity as we look at trends, population trends, and also trends over time. So this map that you're seeing, it's from the World Obesity Federation in different color-coded greens. The darker it is, the more obesity that we have. And if we zoom in on Africa, and if you look at Southern Africa and East Africa, it's shaded deeper shades of green. This is really showing that in this part of the world where obesity is an issue, so is HIV. So this is a concern for us here in this room and on the continent. So the growing obesity epidemic is in all regions of the world. We've had this big drive to move people from efavirenz-based regimens to dolutegravir in most parts of the world. And some specific ART, dolutegravir being one of them, is implicated with weight gain. But I must say all antiretroviral treatment is associated with weight gain. And this weight gain can lead to greater metabolic risk and type 2 diabetes, while we don't quite understand the factors. So obesity is a multifactorial disease. It's complex, it's relapsing, and we don't quite understand how it works. But what we do know, and this might be depressing to a few people in the room, is that most of obesity is heritable. Up to 70% of what we understand about obesity is before you've even eaten the most delicious piece of cake. Our environment as well, how much we've walked. For us here at the conference, we probably have walked more in these last few days than we do in our usual lives. We're sitting down in front of a computer, we're driving where we're going. Certain behaviors as well, such as overeating, and we saw how we were during the pandemic, where we were all baking banana bread, we weren't moving as much. So all those things, what we call an obesogenic environment, contribute to how obesity is a multifactorial disorder and how it's difficult to treat. And there are different risk factors in the general population as well as people living with HIV. So general risk factors include older age. There are 3 time points in a person's life where you will gain weight. Puberty being one of them. For women who have children, this is around the time that they have a child, and menarche being the 3rd one. So older age is associated with weight gain. And with that, all the other chronic diseases of aging, hypertension, diabetes are also risk factors. Central obesity, if you have central obesity, that's a risk factor as well. A family history, as I said, and social inequality. I'll speak about this more in subsequent slides, where you will find when an obesity transition, where we're finding that people who have at lower socioeconomic status, because they're less likely to get nutritive food. Good food is expensive. You know, the cost of quinoa, processed foods, highly palatable food is what we call delicious food, is cheap and readily available. For people living with HIV, there are some HIV-specific risk factors. Exposure to older ART regimens, which are fortunately not available as much in our settings. Some of the older PIs, stavudine that we used, and AZT in this region. Chronic systemic inflammation. This is something that we're also trying to understand, and how does that cause, like any chronic disease, if you've had TB, if you've had a cancer with treatment, there is some weight gain. And HIV is a similar disease process. And there's also possible adaptive immune activation. And about our current regimens at the moment, of concern is TAF in particular and dolutegravir, but also some other drugs in the pipeline. So the pathophysiology of obesity is poorly understood. But what we do know is that HIV itself, as well as antiretroviral treatment, do something to the adipocyte cell. This has caused, if you see the picture in front of us, there's actually a change that happens both with HIV independently as well as antiretroviral treatment. We don't know why quite this happens, but chronic inflammation, fibrosis are some of the things that are associated with the change of the fat cell in people living with HIV. So while obesity is an issue among all of us, among people living with HIV, there's a special mechanism. In particular, women, people, black people, and people who had advanced disease when they started disease are particularly at risk of these effects of the change of the fat cell. So, but what we do know is that all modern ART causes weight gain. So this is true. There's been a lot of observational and clinical trials that have been done in different parts of the world, and they've all shown us that ART or modern ART causes weight gain. Here we show ADVANCE, which is an African study that looked at people randomized to one of 3 regimens. The dark blue at the top, which was TAF, together with DTG and FTC. The second line, which is the orange line, was TDF with DTG, and the last line in orange, in green, is looking at efavirenz-based regimens. But as you can see, over 192 weeks, there was weight gain in both men and women. So the weight gain that we saw in both sexes over 192 weeks was roughly 9 kgs in people in the blue line, 6 kgs in people in the orange line, and about 3 kilos. So over time, in almost a 5-year period, we're seeing a gain in weight. And we're not sure when it will plateau necessarily. So if you superimpose this on our programs and people who are going to be on ART for 10, 20 years, what does this mean? We don't know, but it is of concern. Another thing that we know is that integrase inhibitors, TDF and TAF as another drug, have been associated. Another study, this was an observational study, a follow-on from ADVANCE, where 172 people who were part of the ADVANCE cohort. This paper was released towards the end of last year. And people who were on TAF and DTG within the trial, 52 weeks later, which is roughly a year, lost about 1.2 kilos. And people who are on efavirenz, TDF, gained about 2.9. So what we do know about this is that there's something about TAF that we don't quite understand that may be associated. But is it TAF itself, or is it what TDF does to keep weight low? Same with efavirenz. There have been some studies done by Pharmacokinetic, University of Cape Town, where they looked at certain genes. So people who are slow, fast, and intermediate metabolizers of efavirenz, there was a difference in how much weight gain that they would, how much weight they would gain. So it's not efavirenz keeps you thin, it's because it's toxic. And some people who are slow metabolizers are more likely to gain weight. So this is just summarizing what we know. So as I said in the previous slide, TDF and efavirenz, there's something about TDF and efavirenz that keeps your weight low. And we know women in particular, across all studies in different cohorts, French cohorts, American cohorts, and African cohorts, women in particular are gaining weight. So there's something about the female sex, Black people in particular, people who are on TAF, people who are on DTG and bictegravir, and that return to health phenomenon. But as we've seen in ADVANCE in the previous slides, it's more than just the return to health, because people gained more weight than we would expect as a return to health. So this is just a good summary of the evidence that we know so far. But we have a lot of unanswered questions of why, we know there's risk factors, but there are certain drivers and consequences. So we know the drivers, integrase inhibitors and TAF, certain demographic factors, as well as urbanization and lifestyle factors. Obesity is linked to over 230 diseases that we know of, ranging from mental health issues, adverse maternal birth outcomes, cardiovascular diseases and stroke, metabolic diseases, certain cancers, Alzheimer's, and the effect on mobility and on daily living. And people living with HIV on this continent are fairly young. So we are finding people in their 30s, 40s who are having all these complications that usually in other populations we're seeing a decade or two later. And what we do know is that if we target obesity, we've got the ability to delete chronic disease. So as we're looking at obesity management, it's just not looking at management of excess weight and adiposity, but it's preventing an epidemic within an epidemic where we're seeing hundreds of thousands, potentially millions of people who are gaining weight, who are young, who are in a healthcare system that's unprepared, where we do not have enough answers to know what to do with obesity. And this is something that is really concerning. So I'll now speak about some of the things that we can do. But before then, in pediatric populations as well, we often don't talk about children. Childhood obesity has doubled. It's a big issue. And it's important for us to work on childhood obesity. Again, not being the bearer of bad news, most people in this room, if you've gained weight, losing weight is very difficult. But if we're able to work to intervene before obesity occurs in younger populations, that prevents obesity in adulthood and prevents all these cardiometabolic issues and cancers that can happen. So in our pediatric populations who are exposed to ART 20 years more than the average adult, this is a place that we would like to act on earlier, if we can, in adolescence and in childhood. Weight stigma or weight bias is a big issue. Children and adolescents, as well as adults who have excess weight, are often bullied. You're less likely to get a job if you've got excess weight. You're less likely to get a promotion. And in healthcare facilities, we have a lot of bias. One study showed people who presented at an ER with appendicitis, people who had excess weight were less likely to have intervention, and that resulted in them having complications to appendicitis. So as healthcare workers, we carry weight bias and stigma as well, and we should be aware of it. So this is just summarizing what I've spoken about so far, but looking at the bottom where we look at the adaptation. Weight loss is very difficult. Our body defends against weight loss. For most people here who've started some sort of weight intervention, you lose weight in the first couple of weeks, but the effort that you have to take, whatever you're doing, takes more. So you lose weight in the first couple of months, then afterwards, it looks like you're doing so much and you're not losing weight. It's because our bodies adapt and defend against weight loss, which is quite unfair, but any weight loss intervention eventually does not work out because our bodies adapt. And this includes some of the drugs. So what are the possible strategies that we have? Well, we can switch ART regimens. There are some lifestyle interventions, public health interventions, medical therapy and surgical interventions. Medical therapies, anti-obesity medications are very exciting because this could be a game changer within the field. So going through some of those interventions. There is a trial that's being done by the ACTG group where they looked at people who had BMIs above 30, who had gained above 10% of their body weight. It's called the DO-IT study. We don't have results as yet, but what they've done is they've randomized people to one of three arms. You're either on doravirine with TAF and FTC, doravirine with TDF, or you are on an integrase inhibitor. And people are followed up for up to 48 weeks. So the results are not available as yet in the public domain, but this is one strategy of switching ART regimens. However, we don't know if this quite works. How much weight is too much weight before we switch? We saw within ADVANCE, some patients were changed, a few number of patients were changed from dolutegravir to efavirenz. That didn't make much of a difference. Our second thing that we can look at is behavioral modification. This is what we talk about a lot when we give lifestyle: exercise more, eat, move more, eat less. This doesn't actually work out. This is a few studies that look like all the interventions that you can think of, way less, et cetera, et cetera. And as you can see, everybody always loses weight during the intervention, and more people gain weight more than they were before. So behavioral modifications have not quite worked. Surgical interventions. So here I'll talk more about the sort of drugs that we have available. Phentermine and topiramate is a drug that we've had available for a long time. It's available for us. It's got some side effects, but there's a new class of drugs, GLP agonists, liraglutide, semaglutide, tirzepatide. And this is potential game changer because we're seeing weight loss equivalent to bariatric surgery. Some studies we've seen up to 20% of weight loss within a year. That's really a game changer. But with all these drugs, if you stop taking them, like any chronic disease, your weight does rebound. And the fourth one are public health interventions. Education and awareness campaigns. We've got food deserts where people don't have access, especially in urban areas. They don't have access to nutritive food, physical activities, policy changes, such as reducing the sugar and sweetened beverages, and community-based interventions, walking, making sure that people are safe to exercise. And also, last month, the WHO released guidelines about integrating and preventing the control of non-communicable diseases, which includes obesity. So these are guidelines, implementation guidelines that give us some guidelines, especially in this part of the country. However, we've got a few unanswered questions. So I think anyone who's been following the news, Ozempic seems like it's this magic bullet around, which is semaglutide, around weight loss. Do we know if these interventions will work in people living with HIV? We do think that they will work. However, we don't have a lot of longitudinal data. And even in people without HIV, the sort of time that we have is about 60 months on treatment. So we don't know how long these drugs can work for everyone. Some other unanswered questions, and where we need some research as we go on obesity transition. And I would like you to look at stage 1, where most countries in sub-Saharan Africa are, where women have more weight than men, higher socioeconomic status opposed to low socioeconomic status, adults more than children. And you'll find in one country, South Africa, for example, you're having people across different epidemiological transition within obesity. So your public health interventions, individual interventions have to be targeted to where you are. Yes, yeah. So there's some unanswered question, and I'm coming to the concluding side. The costs, these drugs are expensive, the length of treatment, stigma of weight loss. If you're losing 20 to 30% of weight on these drugs, what does that mean in a stigmatizing environment? We don't also have guidance of managing obesity among people living with HIV. So the takeaways that I would like to leave you with today: all ART does cause weight gain. It's multifactorial. The management of excess weight is hard, but it's possible. We don't know enough at the moment, but we do need culturally appropriate, affordable, and scalable interventions, particularly in this part of the world, where this is a potential crisis that I think we don't have enough to deal with. Thank you for your attention. I would like to thank my colleagues who have helped with this presentation. We've got a special session towards the end of the day that will contextualize some of my talk. And I would like to thank some of my colleagues for help with this presentation. Thank you.